Okay, let's count the teeth in this patient. We've got an 8, a 7, a 6. This looks very odd, but it's actually a patient who's had the 5 extracted and the 4 has rotated. It's also heavily restored. It's rotated so it looks more radiolucent because we're actually looking at this root mesiodistally, and therefore it's not so thick as a normal tooth would be in that plane. So we've got 8, 7, 6, 5, 3, 2, 1, 1, 2, 3. Again, 4, and then 6, and a 5, and a 7 and an 8. Something's seriously wrong here. We've got a premolar either side of the first molar. This is an abnormality called transposition. Very occasionally, teeth can develop out of their normal spatial order. Now, the name is really immaterial, but that's what we call them. But the important thing is simply to identify that this has occurred. In many cases, it has no clinical impact. This way of aligning the teeth is going to be perfectly acceptable to the patient. It's not going to cause any clinical problems. But the term to use is transposition. Another patient. The 7s have erupted, the 8s are in development, so it's a teenager probably. What can we say about this patient? Well, if we count the teeth, we've got 8, 7, 6, 5, 4, 3, and 1. So we have a missing lateral here. 1, 2, we've got a peg lateral. 3, 4, 5, 6, 7, 8. 8, 7, 6, 5, 4. These teeth are just overlapping, which is why there's a increased radiopacity. 3, 2, 1, 1, 2, 3, 4, 5, 6, 7, 8. So our problem here, apart from the peg lateral, if you can consider that a problem, is we have a missing lateral incisor. If we have missing teeth from the dentition, the fancy name we use is hypodontia. Hypodontia is most commonly seen because third molars are missing. But the other commonly missing teeth are upper lateral incisors, lower premolars, particularly the second premolar, and lower central incisors. It is a normal variant, and to find individuals with missing teeth is really very common. In fact, some of you listening to this seminar will have some teeth missing from your dentition. But it is associated with certain syndromes, for example, Down syndrome, where it's quite common to have a few teeth missing, and a very uncommon condition, but one which is widely recognized in textbooks and in dental examinations for students, is ectodermal dysplasia. When we see a patient like this who has only a small proportion of their normal permanent dentition and retention of many deciduous teeth, we sometimes call this oligodontia, just meaning that there are collections of teeth missing, several teeth missing. Personally, I would just continue to use the term hypodontia rather than to complicate matters. But this patient has a 6, a 5, central incisor, 5, 6, 7, 6, 4, 3, 3, 4, 6, 8. So they're missing quite a few permanent teeth, and many deciduous teeth are retained. Here is a patient in a similar state. How many permanent teeth can you identify here? Well, all 4 first permanent molars are present, and we also have a second permanent molar on the patient's lower left. Apart from that, I think all we've got are the 2 upper central incisors. I think everything else here is deciduous. Note what's happening to this tooth in particular. There obviously has been some physiological resorption, as is often the case, even when there's no permanent successor. But the tooth has a lower occlusal surface than the adjacent first permanent molar. This deciduous molar with no permanent successor is undergoing a process called submergence. It's something you need to watch out for when a deciduous tooth does not have a permanent successor. It's produced by resorption, but with a little bit of healing of the bone leading to ankylosis of the root of the tooth. With the growth of the jaw, the consequence is that the deciduous tooth may start to sink down relatively compared with the surrounding bone and teeth. This can cause problems. You can almost get a reverse eruption developing and even pericoronal infections occurring. Incidentally, I mentioned ectodermal dysplasia, sometimes asked about in examinations, so it's always worth knowing a little bit about this condition. In fact, it's not one condition but a group of syndromes, all deriving from abnormalities of ectoderm. This is the definition which you can look at, but very often there is a defect of the teeth. And hypodontia and microdontia are very common features, and I've certainly seen patients who have no permanent dentition at all. What do we have here? Well, if you count the teeth that you can see, certainly in the lower arch, we know we've got 1, 2, 3, 4 molar teeth. Now, we shouldn't have 4 permanent molars, and this is a case of hypodontia, extra teeth. In this case, we have a lower 9. It's ectopic, as is the lower right 8, and they're actually meeting face to face, as you can see there. The commonest type of hypodontia that you probably come across as a dentist, though, is a small rudimentary peg-shaped tooth developing around the midline of the maxilla. This is a mesiodens. So remember this shape, this appearance. It's really relatively common. You may find these just by chance on radiography, because very often they don't affect the eruption of the adjacent teeth, typically because they're rather palatal to the side of the roots of the developing teeth. But if they are centrally placed in the arch, they can interfere with eruption. Occasionally, these additional teeth, these mesiodens, can erupt in the midline. And then the appearance is very odd, but they're easily recognized clinically. Here's one on a cone beam CT scan where we've reconstructed a panoramic image. You can see it here, and here you see a much better image of it. And this one is inverted. It's actually growing up towards the nasal cavities, which is very common. So an inverted mesiodens is not an unusual finding. They usually cause no problem at all in this situation and can be left well alone, although like any unerupted tooth there is a very small chance of cystic change developing. But in most instances these will happily sit there throughout the patient's life and cause no problems. This patient is a little more unusual, but not unique, in that they have 2 mesiodens. This is the midline here. This is the right nasal cavity, the left nasal cavity. Here is a mesiodens which is transverse in the arch, and we're looking down the root canal. You can also see that the follicle around the crown of the tooth is a little bit widened from a normal situation. It's possible that this is undergoing a cystic change. And I would certainly want to keep a close eye on this, even if I didn't do anything about it now. But on the other side, just to work out what you're looking at here, this, if you look where I'm putting the cursor on the screen, this is the outline of the central incisor. This is the lateral incisor here, and this rather large rudimentary shape of tooth is another mesiodens. In this case it's erupted. So we have lateral, central on the right, mesiodens, central, lateral. You'll note that both of these mesiodens are not absolutely in the middle of the maxilla. In some respects, the term mesiodens is a little bit of a misnomer. They don't develop exactly in the middle. They will always develop to one side or the other of the maxillary suture. We can refer to extra teeth, hypodontia, as supernumerary teeth. It's a term that's very commonly used and is perfectly acceptable. However, we also have another term which just confuses things, and this is called supplemental teeth. Supplemental teeth are supernumerary teeth which resemble in every respect a normal tooth. Think back to the mesiodens, which was a very rudimentary small tooth. But here, this patient on the top right has not 2, but 4 premolars in this quadrant. 2 erupted and 2 unerupted. Now, morphologically, they are normal. They are absolutely identical to each other. And I certainly could not decide whether the 2 that were erupted were the true teeth and that these were supernumerary, or whether these were the real teeth and these were the supernumeraries. They're morphologically the same. And in that context, a term called supplemental teeth is sometimes used. Quite frankly, I think it's a confusing term and totally unnecessary. Be prepared to just call them supernumeraries, and you can't go wrong. Here we see 2 erupted premolars and restored, but here we see another premolar. I think in this instance I would definitely not call this supplemental, because although the crown is morphologically the same, the root formation is so clearly far behind the others that this must be the extra tooth. Have a look at this patient, and I challenge you to count the teeth. No, you're not going to, are you? I thought not. Because there are far too many unerupted teeth to count, or it's all very confusing. Down here we have at least 5 premolars. Here we have 4 premolars, if that's a canine. The striking thing about this patient is that they have not only extra teeth, but failure of eruption of teeth. And we also have, strangely, retention of deciduous teeth. That's a deciduous molar, that's a deciduous molar. This is a deciduous canine, another deciduous tooth, here, 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 and here. So the paradox of this patient is that they presented saying they hadn't got enough teeth, that they were keeping their baby teeth too long. Try and work out the age of this patient and you'll soon realize that they're actually an adult. Their 3rd molars have fully formed roots. Yet look at the skull of this patient and look at the physical appearance of the patient here. When we look at the skull, we'll notice some abnormalities, even with limited understanding of the radiology of the skull. There are too many suture lines in this patient, far too many. And the fontanelles, something that we see in children, in babies in fact, are still patent. This is the same patient as I just showed you on the panoramic radiograph. And here we have a remarkable appearance of a patient who can approximate the shoulders in the midline. This is a case of cleidocranial dysostosis, or cleidocranial dysplasia as an alternative name. In this condition we have abnormalities of the clavicle, hence the cleido part of the name, and of the cranium, hence the cranial part of the name. Paradoxically, the patients have most problems related to their teeth because they have supernumeraries, multiple supernumeraries, and failure of eruption of teeth. And those are the things that really bother the patients. But it's useful to remember the sort of other skeletal abnormalities that develop. Let's move on to a group of conditions called odontomes. Odontomes include something very simple, and that's the enamel pearl. If you look at this patient's radiograph, apart from the gross caries in this lower 3rd molar, you may notice this little rounded radiopacity overlying the root. This is a projection of the tooth, a little bit of dentine core, but with a surface layer of enamel. But we're in the root of the tooth here, we're below the amelocemental junction. This little accessory crown almost has grown from the side of the root. It's shaped in a sort of spherical shape, hence the name enamel pearl. In practice, if this is very superficial, as here, it can cause food problems, packing, plaque retention, and you can get local periodontal disease. Beware, however, of cutting this little enamel pearl off, because almost always there will be a small projection of the pulp into this pearl, and you can expose the pulp very easily. In this particular example, of course, I think it's academic, because I think we'd be taking this tooth out, wouldn't we? A really quite frequent anomaly, and one that you should be able to recognize by pattern recognition, is the compound odontome. This anomaly of teeth presents as a localized area, typically no bigger than 1 centimeter, of denticles, small, independent, tiny teeth within a fibrous sac, and that's the radiolucency around the edge, typically developing in the anterior parts of the jaws. Small denticles, each with a crown, a root, enamel, dentine, pulp, but in this little fibrous sac. Totally benign, they stop growing as teeth stop growing, but they will remain there throughout life unless they're removed. They may be a reason for non-eruption of permanent teeth. Remember, the typical site is the anterior parts of the jaws. This is a classic presentation of a compound odontome. Sometimes they look almost like a little bunch of grapes. Here is the crown of a canine which has failed to erupt, and the reason the x-ray was taken was because the canine had failed to erupt, and this was just a chance finding. Here is a cone beam CT scan of someone who had a compound odontome in the anterior mandible with failure of eruption of some permanent teeth. This is the reconstruction in the sort of panoramic view, and you can see this collection of little tiny teeth. You see it very well here as well. So many, many small denticles here. The third type of odontome is a complex odontome. This is far less common than a compound odontome, but it's notorious that dental students get these mixed up in examination situations and call them by the wrong names. Here's a little hint: a complex odontome is complicated in terms of its structure. It does not consist of little teeth, but of one big mass of mixed up enamel, dentine, cementum, pulp, completely haphazardly arranged, so there's no recognizable dental structures within it. This is a particularly large complex odontome. Often they're quite small, but these are usually found in the posterior regions of the jaw. They are, however, far, far less common than compound odontomes. As a dentist in practice, you'll probably never see a complex odontome, but you will certainly come across compound odontomes. Let's have a look at some other abnormalities. In this case, we're looking at the bone, not the teeth. Now, do you notice anything here at all? Well, of course, some teeth erupted. We've got a normal looking jaw with a cortical plate at the lower border. Here's the hyoid bone, which is a normal finding. But do you see this radiopacity here overlying the roots of the teeth? On the occlusal radiograph, you'll see why we have this radiopacity. It's this bulbous projection of the lingual surface of the mandible into the floor of mouth. It's a thickening of the cortical plate. This is torus mandibularis, which, as you should know by now, is a normal variant, a thickening, as I said, of the cortical plate on the lingual aspect of the mandible, and is usually bilateral. It's a clinical diagnosis, or it should be if you've examined the patient's mouth properly, so radiologically it should never be a surprise to find it. But on the radiograph it will appear as a rather blurred shadow on panoramic radiographs. Periapical radiographs, really it can be a problem to take a radiograph because the imaging plate will want to sit on top of this projection of bone. So you may simply not get a good radiograph of the teeth. But if you place the imaging plate here in periapical radiography, you will again see this radiopacity across the tooth roots. There is a comparable phenomenon in the maxilla called a torus palatinus, and here we see a clinical example of a patient with a torus palatinus, a benign growth of the palatal vault. This is bony, hard in the midline and is not a significant finding apart from the context of denture construction where it can present significant problems. Radiologically, you would see a radiopacity in the midline on the assumption that the imaging plate is positioned on this side of the torus if you're radiographing these teeth here. Sometimes it can simply be an obstruction to taking periapical radiographs. What do you think about this patient's jaw? Well, I hope you're noticing the unerupted teeth, of which there are several. But notice also the density of the bone. All the bone, both maxilla and mandible, are exceedingly radiopaque. Now, in the previous seminar, we talked about sclerosing osteitis due to inflammation and infection, and we have got a little bit of that around this tooth here. Beyond the radiolucencies, the granulomas or chronic abscesses on these roots, we can see a slightly whiter bone, more radiopaque, and this is sclerosing osteitis. But beyond this, all the bone is radiopaque, and we can really see the inferior dental canal standing out because of the dense bone, which is almost uniformly cortical. In the maxilla, again, very dense bone. And this combination of very dense bone, often accompanied with failure of eruption of teeth, is a condition, an anomalous condition inherited called osteopetrosis, or marble bone disease. You should read up about conditions like this and try and understand how they're inherited and what the consequences are for the patient other than the dental problems. This patient attended dental casualty at the hospital complaining of toothache on the lower right. Not surprising considering the condition of these two molars. The dentist took a panoramic radiograph, but strangely, after the teeth were extracted, simply discharged the patient. I hope you wouldn't have done that, because we've got a lot of very odd findings here. We have several unerupted teeth. We also have multiple radiopacities. There's a strange one overlying the ramus here. We have odd patchy areas of radiopacity in the jaws. This is a condition called Gardner's syndrome, although the proper name is familial adenomatous polyposis coli, or FAP for short, but most dentists would call it Gardner's syndrome because it's easier to say if nothing else. This is an inherited condition in which there is, from a dental perspective, multiple osteomas of the jaw and failure of eruption of teeth in many cases, and sometimes the development of supernumeraries and odontomes. We've just been talking about odontomes. I think that that's a small compound odontome. The significance of this condition is not, however, in the teeth and the jaw appearances. The condition affects, strangely, the bowel, and these patients have multiple polyps in the bowel. Very strange connection to the teeth indeed. But the important thing is that these polyps in the bowel will become malignant in time. And this is one of the rare occasions where a dentist can identify a patient who may be going to suffer from cancer in another part of the body and can identify them before that cancer develops. So a really important condition to remember is Gardner's syndrome. Multiple osteomas, benign tumours of bone, both externally with lumps developing and internally patchy radiopacity, failover eruption of teeth, sometimes supernumeraries and odontomes. Another jaw abnormality here. This is a patient who presented with a facial asymmetry, and in fact this child was born with the facial asymmetry, and it is really quite a dramatic one. It's so abnormal that it's really made it very difficult to take a decent panoramic radiograph. But what I hope you'll notice is that this side of the mandible is of normal size and shape, but this size is grossly abnormal, with a very small condyle, very small coronoid, a very short ramus, and this accentuated notch just anterior to the angle. This is called an antegonial notch, but very accentuated. This is a patient with hemifacial microsomia. This is not an inherited condition, but it is a congenital one, and it's caused by a vascular abnormality in the first and or second branchial arches during embryonic development. You should read up about this condition to understand it a little bit better, but the clinical consequences are gross facial asymmetry, often deafness on the affected side, so there are ear abnormalities as well, and obviously orthodontic problems for the future. Interestingly, this young boy also had facial asymmetry, clearly nothing like as bad as the previous patient, but he was not born with the abnormality. Look closely and you might see that this side of the jaw is shorter than this side. It's relatively subtle, but it was there, and it was getting worse. It started to develop when he was about 2.5 years old and was just generally getting worse. Now, if you count the teeth in this patient, you'll see that there are some dental abnormalities as well. He had lost some deciduous teeth here due to caries. But if we look at the permanent teeth and count them, we see 7, 6, 5, 4, 3, 2, 1, absolutely normal. 1, 2 may or may not be present, but this tooth here looks rather small, so I'm not sure if it's a 2 or a 3. 4, 5, 6, possibly, but no 7. The 6 has almost no roots. This deciduous canine has almost no root. So we have a very strange situation here, where we have a mixture of poor development of the bones of the jaw, missing teeth, at least one missing tooth here and a missing 7, and arrested root development. Something that has both affected the tooth development and the bone development. Now, I could leave you to work that out like a detective, but in fact there's a close-up of the image there. Look at that root development. But this is a case of radiation therapy. This child had a malignancy of his eye during when he was about 18 months to 2 years of age, and it's affected the growth of the jaw on that side, and it's also arrested root development and prevented development of the 7 and one of the teeth here, either the canine or the lateral incisor. Here's a final cause of facial asymmetry, and I wanted to show you this just to show that while we're usually thinking of hypoplasia of the jaw on one side. Here we're thinking of hyperplasia. This time the abnormality is on the larger size, and we see a very big condylar head, a gross bowing down of the mandible on this side, and a change in occlusion, although that's not apparent from this radiograph. This is something that developed in this patient during teenage years, so they weren't born with it, wasn't inherited, and this is a condition called condylar hyperplasia. This is due to overgrowth of the condyle. Now this may manifest as an increase in size of the jaw, a faster growth on the affected side, or in some patients that the affected side doesn't stop growing at the normal age of around about 21. So you get a gradually worsening facial asymmetry in late teenage life or early adult life. The treatment for this is usually surgical, either by surgery to the condyle itself, or waiting until the growth stops, which it usually does on its own at a later age, and then undertaking osteotomies to improve the facial appearance. I hope that you can see that this jaw abnormality is grossly abnormal. Whereas the maxillary antrum? Where is the maxillary antrum here? Where is the normal anatomical shape of the jaw? Where is the inferior dental canal? The normal thickness of cortex is gone, and we have this strange lacy pattern developing in the medullary cavities. Very odd appearance. This is another case of pattern recognition. If you see one of these, you probably recognize it when you see it the next time. This is a case of thalassemia. Please read up about thalassemia and also sickle cell anemia to understand the possible consequences on radiological appearances of the jaw. Thalassemia in particular is associated with facial bone changes. This is an abnormality of hemoglobin. The consequences are that the patient is anemic and the bone cavities are converted to places of blood cell production, red blood cell production. This leads to very characteristic changes within the jaw bones. It also leads to obliteration of the maxillary sinuses and often a facial bone shape change. Thalassemia is particularly common in patients from around the Mediterranean Sea, often in Greek patients, for example, and this patient was actually Greek, as we can see from the name there. It looks like a Greek name anyway, and is really very characteristic in appearance. Try and remember that. That is probably quite enough for you on anomalies of the teeth and the jaws. We covered an enormous amount of ground there, and this is really again an example where you need to go through this seminar more than once to try and get a hold of the key ideas. If I have a bottom line message for you though, remember two common anomalies: dens invaginatus and compound odontomes. Those are really common in the great scale of things, and they have a very characteristic appearance, and therefore you should go back at least and look at those again.